Hi, everyone. Welcome back to the hashtag #CArthritis event here on Arthritis Broadcast Network, hosted by arthritis consumer experts. It is really my privilege and honor to be sitting here today with Dr. Lihi Eder, who is the co-director of the Cardio-Rheumatology Program at the Women's College Hospital and research director of the Canadian Rheumatology Ultrasound Society. You're focused specifically on understanding the risk factors for developing arthritis among patients with psoriasis. And your focus really is on identifying methods via imaging, so X-ray, ultrasound, any way that one can image the body, and genetic tests and looking at biomarkers for improving early detection of psoriatic arthritis. And we know how important that is in all types of arthritides. Your research also looks at cardiovascular diseases in patients with rheumatic diseases and conditions. And I assume that includes a very special interest in psoriatic arthritis as well. So we're very, very honored to have you part of the program. Welcome.
Thank you.
Dr. Eder, what lured you into rheumatology?
Okay, so I'm originally from Israel. I had really good mentors there. I think many of my choices were influenced by the people that I admired as a student and as a trainee. And I really had someone who was a role model for me. And I said, I want to be like him. And he was a brilliant rheumatologist. And he was both very smart and very empathetic. And yes, I've been with him for 6 months, and I said, okay, I want rheumatology. And I think, rheumatology combines the essence of internal medicine, very complex medical conditions, as well as seeing patients and developing relationship with patients for a long period of time. So I think, that this combination of the intellectual thinking as well as the relationship that we develop as rheumatologists with our patients really attracted me to the field.
Yeah, it's so funny when we ask that question, Dr. Eder, that is generally the response that we get. People find it a very fulfilling medical profession on its own because of the fact that you do get to work with patients. It's not just, oh, here's the script and out you go. It's a lifelong relationship, hopefully, for both you and the patient. That your interest, research, and clinically is with patients who have psoriasis. And we're not generally talking, I suppose, about mild psoriasis. We're talking about people who have significant plaques and significant skin presentations when we talk about psoriasis. Tell us a little bit about those types of patients that you're working with daily in both your research program and your clinical practice, and what makes them unique and go on to develop the arthritis portion. We have members, Dr. Eder, who come to us and say, well, I heard I might get arthritis. And we're saying, hang on, maybe not. You're going to demystify this for us. Or try anyway.
I'll try, yes. So I think, so unlike other types of diseases like rheumatoid, where you kind of have a blood test that you can do and find rheumatoid factor positive, which occurs in many patients before even the development of symptoms. In psoriatic arthritis, we don't have such tests. So we rely on detecting the skin disease as a marker for us to identify people that are maybe at risk compared to the other general population who do not have psoriasis. So this is sort of the group of interest, the target group for us to investigate early phases of disease and try to identify risk factors and who is going to be at a higher risk of developing this condition. And I've been very fortunate to work with Dr. Daphne Gladman, who is, I'm sure you know.
Oh, I know Daphne very well, yeah.
She's one of the pioneers in the field. And as a trainee, I started working with her, and my PhD was on this very unique cohort of patients with psoriasis that we've been following them for for a long period of time, and we evaluated them even if they did not have or any musculoskeletal symptoms. So we used to see them every year and ask about, do you have joint pain, do you have stiffness? And then some of them developed arthritis over the years, and we were able to analyze the data and identify some of the features that put people at risk for arthritis. And we did find some findings like the severity of the skin disease, the nail psoriasis, having uveitis, which is inflammation in the eye. There were some factors that identified people that might go on to develop psoriatic arthritis. Another important finding, I think, that was unique and was then led to additional research around the world was the fact that many people with psoriatic arthritis develop joint pain and stiffness and fatigue many years before we can detect as rheumatologists swollen joints. So this was sort of unique because it meant that we as rheumatologists, we tend to consider swollen joint as the ultimate finding
right.
that determines the diagnosis. And if we don't find them, we said, oh, maybe it's something else. Maybe it's fibromyalgia. Maybe it's osteoarthritis. And we tend to sort of discharge maybe these patients and rule out the diagnosis of psoriatic arthritis. But what we learned from this study is that, in fact, these patients are at higher risk of later developing these typical findings of psoriatic arthritis, like swollen joint dactylitis. So we cannot ignore these symptoms. We cannot say as rheumatologists, just because right now we don't identify any swollen joint, it doesn't mean that you may not develop it in the next year or next 2 years. And that led to the recognition that there is a sort of a prodromal phase, a phase where people start to experience symptoms, even though on the physical examination, there is really nothing. And it means that we need to do better in terms of findings, biomarkers and tools such as imaging, such as blood tests that might help us as rheumatologists identify these patients earlier.
Yeah, so once you find some of these factors that you've been talking about, so you dug around in the data, you figured out, hey, the people that are presenting with these types of things, and there's chronicity that they last, these people generally are going on then to develop psoriatic arthritis. So, and I always ask this question, so what? So what other questions do you need to ask? And you're now saying you're looking at genetic risk factors, you're digging deeper. But practically speaking, Dr. Eder, so what about the clinical end of things? What has changed, knowing these things, what has changed about the way you would approach that patient early?
It definitely changed my perspective, and I try to convey this information to my colleagues and my trainees that do not dismiss these complaints. And that's something that I learned from my patients, that these complaints, even though as clinicians we do not identify something right now, it doesn't mean that things are not going to change next week or next month or next year.
Yeah.
So maybe I should book an appointment for these patients for 6 months from now, for 1 year from now, and maybe I should order imaging to identify subclinical inflammation. I have ultrasound in my clinic, so that's a benefit for me, that I often detect inflammation in the ultrasound, whereas the physical examination is completely normal.
Right.
So I definitely, these studies triggered me to use imaging more, and I encourage my colleagues to do the same.
Do you change as a result of those extra questioning, like the ultrasound? Does it change your prescription, whether the prescription be exercise or rest or diet or medication? Has it actually changed early, before joint implications? Has it changed the way you treat the patients?
So definitely, if I would identify inflammation in the ultrasound or in the imaging, I would start treating as soon as possible. That's definitely something that I would do, with the hope that it will prevent the full-blown psoriatic arthritis, development of joint damage, and so on. What I usually recommend to people, if I don't find any findings of inflammation and imaging, and the patient is still complaining of pain and stiffness, and they are asking me what I can do to reduce my risk, I would say at this point, the best thing, if if a patient is overweight or obese, I would recommend trying to maintain a normal weight. That would be a recommendation, and there is some evidence in the literature that weight reduction might reduce the risk of future psoriatic arthritis. I'm very much interested in diet as well, and we're now doing a randomized control trial in our clinic looking at different types of diets to improve symptoms of patients. So this is not instead of treatment, this is an additional to treatment, but I do believe that there are some things that we do not understand in terms of what we eat and how we can do better in terms of healthy dietary changes as an adjunct therapy to the
I think people in general, Dr. Eder, are really willing to engage in things they can control themselves. Even they prefer it over having to take a treatment, which of course we're not advocating they do. You need to do the treatment as well as the thing that you can control yourself, such as an improved food eating plan. We try to stay away from the word diet because diets fail every moment, every minute of the day. We like to talk about food as fuel. And what fuel are people going to put into their mouth that's going to best help them deal with the challenge of psoriatic arthritis? And if that means that better fuel choices leads to weight loss, that's a winning strategy, in other words.
Yeah, and I completely agree with you, Cheryl. By diet, I didn't imply that people necessarily need to lose weight. In fact, there are some studies that suggest that it's sort of what we eat more than the actual weight that we lose.
And by virtue, if you're putting better fuel choices, you will lose weight if in fact you're overweight, right?
Correct. Yeah.
Yeah. It's super interesting. Let's talk for a second about the biomarkers, because our viewers, our members, the people that find our programming online and through social media, Dr. Eder, are a lot of us are science nerds. And so we want to know kind of what biomarkers are you looking at? Are they similar to biomarkers found in other diseases? Have you honed in on one or two that may show promise? And if you find them, then what? What do you do to those biomarkers?
Okay, so biomarker, I think it's important to first understand what biomarker is. So biomarker doesn't necessarily mean a blood test. It's an objective measure, or unlike, we talk about patient-reported outcomes, and then there are biomarkers, which are things that we can measure to reflect inflammation or disease activity. So my area of interest is imaging. So imaging is another type of biomarker, and I focus on ultrasound because ultrasound is really I consider it as an extension of my physical examination. I first examine the patients and then I target the ultrasound assessment. I have a machine in my clinic and I use it to target my assessment to the joint that is symptomatic. So for me, ultrasound is a way to improve my assessment of patient. And if I identify inflammation or if I identify damage, this means that it may change the treatment that I choose, or it may diagnose a patient as having PSA. So that's kind of one group of biomarkers. Then there are other types that most people refer to as laboratory biomarkers, so blood tests that we take and then we measure different things. CRP is obviously the measure that is available to all of us. It's a measure of inflammation, and we know that it's good to identify patients that are at high risk, but for developing joint damage. But unlike rheumatoid, it doesn't function as well in PSA, and there is a lot of interest in identifying new biomarkers. I can tell you that we are now doing a study with a method that is called CyTOF. So CyTOF is a way to identify the profile of the different immune cells in the blood,
Yeah.
the different T cells, the different B cells, the different cells that are part of our immune system, and try to see whether we can predict response to different biologic medications. So obviously right now as rheumatologists, we have several groups of biologics. We have the IL-17 inhibitors, we have TNF inhibitors, and we don't know which one will work best for a specific patient. So the goal here is...
You're talking about personalizing an approch. Yeah.
Exactly.
Yeah.
Exactly.
Yeah, that's fascinating. I didn't know about this special metal. You got to form your own heavy metal rheumatology band now that you have a metal.
Yeah. So we'll see if it works.
That's amazing. That's incredible. You know, when I was diagnosed, Dr. Eder, we had one biomarker, and it was your art of conducting a physical exam, literally.
Yep. Yeah.
And now, you know, I look at the advances over the last 31 years, and you have other tools now, such as the imaging that you've just reviewed with us at your disposal, as well as some of these other laboratory pieces or tools. If we think about the way in which you're practicing today, using these tools in the middle of a pandemic, how has that gone? I mean, obviously it's disrupted people's research, it's disrupted care. How have you managed? And I know this is the talk that you gave at this year's Canadian Rheumatology Association and Arthritis Health Professions Association meeting. Tell us a little bit about what you presented.
So actually I presented more about, we presented a study about COVID risks. That was not so much about how do we deal with the difficulties of COVID, but right. I can tell you from my own experience, and I think that's something that many rheumatologists share, that we lose the physical examination piece, which is sort of impossible to do via Zoom or telephone conference. And I learned pretty quickly that I'm not able to assess new patients. I prefer to bring them in for the initial assessment because otherwise it's just impossible for me to determine what they have. So for new consults and for patients who seem to be active, I always ask them to come in because I find it very challenging. I think I'm concerned that, you know, we might miss or, you know, underdiagnose things through telephone, especially in people who, you know, there are people who tend to underestimate their the level of symptoms. So it's very, very hard. And I've seen
the research shows that our physicians generally regard our disease as being more serious or more active than in fact the patient perceives it to be.
Yeah.
Obviously, because we learn to live moment to moment with it, and then we underwrite perhaps those things. So that's a very important point. There has to be ways. I think what COVID has shown us, though, in this time over the last year, Dr. Eder, is that there are things technologically that can be done. Obviously, you're not capable of feeling the sponginess of a joint by even a sophisticated and well, high-end camera, for example. You can see perhaps pitting on nails if a patient takes a picture appropriately and sends it. But, you know, for myself, my hand function isn't great. I can't take a picture sort of one-handed of the other hand because the camera falls out of my hand. So there are certain limitations for sure. You're looking at the risk of COVID acquisition or getting COVID in your patient population. Is there a difference in people with psoriatic arthritis or severe psoriasis versus other of the rheumatic diseases?
I can tell you that the study that we've done, it's a collaboration with several rheumatologists in Toronto and Montreal. In particular, I want to mention Jessica Whittyfield, who is a clinical epidemiologist. She works from ISIS, and she was the other co-PI on this study. what we're doing is we're using the Ontario administrative health data. So these data are the data that is collected when a physician is seeing a patient. They need to put a billing code and a diagnosis code. And then using these codes, we created cohorts or groups of patients with rheumatic diseases. So different rheumatic diseases, not just psoriatic arthritis. So we had rheumatoid, we had psoriatic arthritis, we had ankylosing spondylitis, lupus, vasculitis, all of the different rheumatic diseases, as well as some non-rheumatic diseases like Crohn's disease and uveitis and MS. And we were interested in several questions. So the first one was, were patients being tested more, and what were the factors that influenced testing for COVID? Because we know that initially testing was very limited and restricted, so we were interested in access to testing. And the second question was whether patients with rheumatic diseases were more likely to contract COVID and whether they were more likely to be hospitalized because of COVID. Because obviously, many of the patients are on immunosuppressive medications and there is concern about risk. So what we found is that patients with these diseases were more likely to be tested across all of these conditions. So we don't know whether this is because they were more aware of this risk, whether they were more concerned, or they had more easier access because they were already connected to a physician, so it might have been easier for them. But interestingly, despite the fact that they were more likely to be tested, there was no higher risk of contracting the virus. So being positive or negative was not related to whether you had immune-mediated inflammatory disease. That was the first part of the study. The second part dealt with hospitalizations because of COVID. And here we found that as a group, patients with immune-mediated rheumatic diseases were at higher risk of being hospitalized because of COVID. And that's very important to know because obviously there are now considerations regarding priorities for vaccinations. So based on this study, we can assume that patients with rheumatic disease, inflammatory rheumatic diseases are a high risk group because they are more likely to be hospitalized because of COVID. So there are concerns from patients and in terms of adhering with recommendations. So it means that I think many people are aware of it, and maybe many people with rheumatic diseases are being adherent with the recommendations, but that's a measure that everyone can do and try to avoid the infection. So
I'm glad that you talked about this research that you've done and in this forum that gets out to the public, Dr. Eder, because it's a really good example of how administrative data research, so using regularly collected data from our healthcare system or your interaction with it as a patient, helps support policymaking. I mean, it's just the most, I think, crystal clear example of the benefit of doing this type of research that you've just shared with us. Each province is probably taking a slightly different approach with vaccine prioritization. And the research that you've done is so critical for ensuring equity in vaccination distribution and administration. We know that in our Indigenous people's population, there are massive equity problems in our healthcare system, and it's this kind of work that we hope can help address that. In British Columbia, the guidelines are, the recommendations are for people like myself who's on a biologic and other immunosuppressive agents, that I will be in the next phase because of the fact that the hospitalization rate is higher, and so the chance of a severe outcome if acquiring COVID is greater. So I'm grateful that you shared that research with us, because it just, to me, is a perfect example. People out in the public go, oh, it's just spending money down, and it goes down a dark hole. They don't understand, how does the public benefit from the money being spent on this type of research? Well, here is a direct way how the public benefits through policy informing. So last question for you. I know you've got a busy day ahead of you there. It is a Monday, and so probably lots of things to get going. Tell us how you've had to manage your own practice with COVID. I mean, apart from, the difficulty you've seen with the new patient piece, the importance of a physical exam, for example. Tell us about the positive experience you've had with perhaps telephone care or video care. We view virtual care as the umbrella term, and it can happen via teleconference or a video conference setting such as this. So tell us about the benefits that you saw, if any.
Yeah, I think there are definitely benefits, and every crisis, I think, brings new technology and things that I think it's going to be very difficult to go back to the way we were doing things. I think it works really well for some patients, and I think it's going to be very difficult to bring these patients back to the clinic because they are so used to it. I'm seeing patients who are sitting in their cottage and talking to me.
I'm one of them. I'm one of those patients. But I'm someone who's 31 years in, Dr. Eder, and I suspect that's probably pretty common, that those of us who have had our disease for longer and really have a great comfort level about our day-to-day decision making, things that may pop up, little aches and pains or questions about medication, we know what to do. And sometimes we just need a quick assurance from even from the medical assistant in your office, the secretary, the person doing your administrative work can even, though they're not a doctor, they can answer a simple question, process a simple refill. So things like that, there's no reason I need to commute, from Barrie into downtown Toronto to see you. So I full-throatedly agree that virtual care should be here to stay, and we maximize use of it in order to save money and spend more time on clinic visits with your more complicated patients, and to invest back in clinical research for sure.
Yeah, and I absolutely agree with you. I think that many patients like you've had lived the disease with many years. I think the benefit, like your disease better than I do. And in many patients, I would ask them, "Do you think you're active?" And they would say, "No, I'm fine now." And that would definitely, even if they are in the clinic, that's, to me, it's a discussion. And I know there are in patients that I've known for years, then I know who I can, who is going to be able to tell me accurately what the status of their disease is. And I for these people, I'm very comfortable doing virtual care. And I think that's obviously, as you mentioned, could allow us more time to spend more time with patients who actually need it. And the other, I think, benefit is that we'll be able to provide more specialty care to really remote areas now that we've experienced with these technologies. So
well, I'm glad to hear your support for that. It's something that we're certainly advocating on. We've just completed a community-based research project on virtual care, and we look forward to sharing our results with you in the very near future. Thank you so much for joining us, Dr. Eder.
Thank you.